Good morning, everyone. Welcome to Houston Methodist DeBakey Heart and Vascular Center Grand Rounds. The Grand Rounds today is on cardiac xenotransplantation, and our speaker for today is Dr. Griffith. But before we get started, I just wanted a few housekeeping items. We are broadcasting live on live stream and YouTube. Please use the microphones to ask questions, and the recording is available for viewing on YouTube. And also, if you have not subscribed to our channel already, please consider subscribing to our YouTube channel. For our viewers, if you would like to submit a question, text DeBakey to 37607. You may also submit questions via live stream feed. And you'll find the video on livestream.com/HMH-edu. And we have 3 conferences which are upcoming. There is a multidisciplinary amyloid conference happening tomorrow and on Friday, and it's a hybrid conference and free for registration. There is a pre-intern training for vascular residents in June, and cardiology for the non-cardiologist on June 17th. So this will, go ahead and get started with Grand Rounds. It gives me great pleasure to introduce Dr. Bartley Griffith. He is Thomas E. and Alice Mary Hale's Distinguished Professor of Transplantation at the University of Maryland. He is the Chief of Cardiac Surgery there and has been since 2001. He is internationally recognized for his work in heart and lung transplantation and mechanical circulatory support and respiratory support. He's led the division's program on complex end-stage heart surgery and also a national expert in surgical embolectomy and PTE for CTAF. He also has had a continuously funded, NIH-funded lab since 1986, and current funding includes areas of mechanical lung and circulatory support. Dr. Griffith is also a founder of Breathe Inc., a medical device startup. And recently, of course, he has pioneered the first xenotransplant of a genetically engineered heart from pig to human, and he'll be talking about it today. Without much ado, Dr.
Thanks.
Griffith.
Thank you very much for that warm welcome and a lovely evening last night. Thank you very much for the kind invitation to speak with you. This is an interest, right? Never has anybody had so many talks on so few patients. When you have a series of one, your outcomes, are either pretty bad or excellent. I think that we have judged the outcome of this experiment as a little bit of wow, a lot of, boy, we really don't know very much. And I think there's enough light in the end of this tunnel to keep working at it. So I hope to kind of review where we are and some ideas in terms of what happened to our patient. Usually in the world of transplantation, similar things will happen and you get it figured out, and so you have an M&M and you know how to maybe do things better next time. There were so many things with this case I know that we can do better, I personally can do better, that might change an outcome of another. The key issue of whether or not this patient rejected, did we transplant a virus with the heart that reactivated? Or did we actually give IVIG that had kind of a preemptive and presumptive role in initiating an acute rejection? Were any of those things interrelated, or was one of them dominant? I'm going to review some of that data with you. I thought I would be speaking, and I think I am, not only with surgeons, but with kind of a transplant-interested group. So I'm going to go through not just the cheesy pictures, but try to give you some data that may kind of help me, because you're going to maybe ask me a question about it, understand better the data I'm showing you, but also help you interpret a little bit of where some of this new science is going. So let's try and see where we can get with that, all right? 55 years before this xenotransplant, of course, it was the Great Bernard case. And, it's a long time. That's 50 years, right? Before, a sentinel change in how we, think about maybe a human heart transplant or not a human heart transplant, how to replace the heart, with an organ in lieu of a human heart. So, you know, we stand a little bit farther behind where Bernard and the teams were then. They had a little more data to rest on and a lower hurdle to basically get over. But I think, you know, science has advanced, and I think we're moving along with it. So hang tight. Okay, so this is my friend Mohammed Mohideen. He's a Pakistani who has been in the United States for most of his life after his training in cardiac surgery. He got very interested in xenotransplantation for a number of reasons. He went to the FDA, went to the NIH, and spent about 10 years there perfecting immune suppression protocols for xeno heart transplantation using the earlier genetically engineered hearts. He used the intra-abdominal heterotopic model because it was easier for him. He didn't have, you know, bypass and all that stuff. So a little bit like those of us that think about rat heart transplants in the belly where lots of immune suppression is worked out. He did the same thing in the non-human primate, in the baboon. So this is the hookup. It's a non-working heart, which is a little bit easier to deal with. And anyhow, he was able to show in this model, and you can see right here, this is an animal whose abdomen is shaved. And you can see something within that abdomen. It's either a big aneurysm, we got to get him to the OR, or there's a piece of meat in there that's contracting, and that's in fact what it is. So this tag on him says 784 days. This animal went on to, I think, 3 years. And the key finding in all this was that an anti-CD40 monoclonal antibody was the secret juice to get these hearts going along. And that is an accessory blockade. Those in the world of immunology will understand this is a key component in T cell and B cell activation. And xenotransplantation is very much B cell oriented and antibody mediated, less so the T cell that we use, that we kind of deal with regularly in the allotransplant model. So anyhow, the key thing was getting these animals out that long, and it told certain people, me included, that maybe this was ready for a primetime test. Could we get that heart out of the abdomen and into the chest of a baboon, taking the role of basically the full load of that animal, basically doing a heart transplant with that genetically engineered animal and treat it like the regimen that these animals had. So we got them to come to Maryland, and for the last 6 years have been working on that project, getting a baboon to survive after a transplant with a pig genetically engineered heart. Well, what about that pig heart? Well, it is complicated, right? That work has been ongoing since the mid-90s. Progressively, the science has indicated what needs to change. The carbohydrate alpha-gal epitopes have been shown to be much of the acute rejection, hyperacute rejection problem. So if you knock those out, and there are 3 of them, they've been knocked out, and that gave a big boon to everything, but there are other genes that have been knocked in now, and one more that's been knocked out. The other one that's knocked out, other than the carbohydrates, is a growth receptor. The growth receptor was necessary because these pigs grow to 500 pounds. And believe it or not, if you take maybe a 30-pound piglet, remove the heart, put it in a 30 or 60-pound baboon, guess what happens? The heart just keeps growing, and it'll outgrow the chest, it'll get thick and be a problem, and the Germans taught us that. So knocking out the growth hormone is kind of interesting because that's a facsimile of Laron syndrome, and that's a dwarfism syndrome, and those are small people who don't have big organs. So it seems like that's working. That may be a way out of this overgrowth problem. So we're testing that. The number of transgenes that have been added basically have to do with limiting inflammation and giving humanoid type control of complement activation and thrombomodulin. So those go in and the epitopes that cause rejection go out, and we knocked out the growth hormone. Well, let's find a patient. This is a patient that showed up. We were thinking we were ready to go ahead. The FDA had told us before a major trial was to happen, it would probably be 2024. Muhammad and I, with outcomes better than 9 months in our own lab, felt that we would be walking on ice for the next 3 years in the lab. No protocol changes. As we did the GLP studies, good manufacturing, good laboratory practice that were necessary by the FDA to get an approval for a multi-center IND trial. A lot of work, a lot of expense, but no additional information to us. The protocols couldn't change. Anybody that qualified a device or a drug knows that. So the lab was going to be shut down just to do that expensive work. We weren't able to do any additional stuff. So we said, do you think if we had the right patient, we're ready now? So we did find a patient. This is the patient. He was hospitalized for 61 days. He was on ECMO for 48 of those days. He had a low white count that kept bombing downwards, 3.2, and his platelet count was 90,000. He's a really sick man. Our immune suppressive protocol included knocking down B cells with rituximab pre-op, ATG, that's to manage the early T cells, and then a C1 esterase inhibitor to deal with complement. Then the routine maintenance stuff included just MMF, like we do in allotransplantation, a tapering, pretty rapidly tapering prednisone dose, and then this red drug called KPL-404, and that was the same kind of drug that we had used in the baboons to manage that CD40. The baboon drug was not made for man and would not do well in man, so we had to kind of find a drug. This drug had never seen humans. It was being prepared by Kininsa, and gratefully they let us use it on this one case. It had never been in a patient. You can imagine that will cause chaos with respect to drug levels, which you will see. Well, this is what happens when you measure in your donor, looking for whether or not the genetically engineered part of the donor that you'd like to use for this patient is true. So the first column is flow, and you can see in the kind of reddish, the reddish glow, that's wild type. That would be a normal pig heart, right? And we're looking at 3 of those epitopes that we wiped out, and you can see on this particular flow run that the control in blue, that is a control animal that we know has had those epitopes removed. And then the donor that our recipient was to get, a clone donor, is A328. So the donor that our patient got is shown there in yellow. And so the idea is to separate the yellow and the blue, which kind of comes out green, from the pink, right? Pink is wild type. What we want to give our patient looks good. The second column is just a Western run of the same thing, only it shows the transgenes expressing, right? All those transgenes that control inflammation and coagulation cascade. And then on the far right is a serum study of the growth knockout. So the growth receptor knockout is shown on the right, where in the wild type it's reading 25 and whatever that means, you know, picomils of something. And then the A328, that's the donor, doesn't have it, right? So we're all set. So we have a donor. So this donor has been evaluated, so it should work as our animal studies had worked if the baboon is like the man, right? So that's what we have to hope. You have to understand, currently the status and state of genetic engineering doesn't let us delude ourselves to think we got it figured out, right? It basically, I believe, brings us to an era where hyperacute rejection will be avoided. And that's like the first 15 days. I don't think any of the immune suppression we talked about giving, including the B cell wax with rituximab and the T cell with ATG, I don't think they're really even necessary because these genetically engineered animals won't hyperacute. Body doesn't see it as something weird, right? Because those carbohydrate things that initiate the hyperacute rejection are removed, right? But the non-gal, that's the gal of those carbohydrate moieties that were removed, the non-gal anti-pig antibodies are in all of us. And even though some of us think we're not piggish at all, we do have anti-pig antibodies. It's ubiquitous. Some of us have more than others, And I'll leave your imagination to think of why that may be. But if you have a high titer of these things, right, you are going to be a harder patient for me to put a pig heart into. It only stands to reason. If you have a low titer of these naturally occurring non-hyperacute type antibodies, right, if you have a low titer, you're going to be like that lower group of animals where they just kept going, right? And they were treated with anti-CD40 ligand 154. But the point of this slide is not to make you dizzy. It's basically you want to stay away from those high dots that are going up. They're not surviving because those were basically high titer non-gal antibody animals. So ideally, we would want to select a patient, certainly for early trials, that had low levels of preformed antibodies that are non-gal. Got it? Okay. It's a little bit like allotransplant, like a sensitized patient maybe, you know. So this is our patient serum, and we're looking at IgM and IgG. And just look at the three on the right. Those are human high. That's a human that has a high anti-pig antibody, right? And we just use that person. He works in the lab in Blacksburg, Virginia, where the animals are cloned. And he just was found to have a high level of these anti-pig antibodies. And we use him as a control. So if you had a high level, this is what your IgG and IgM would look like. And then there's human low. So we have a low titer person in the lab as well. And that's the light blue up there. And then heart transplant patient, that's our patient. It's actually xeno heart transplant patient. So you can see in the IgM area, we're looking a little better than we are in the IgG. So, you know, we weren't really sure, is this a good sign? Is it a bad sign? There seems to be more concern experimentally with IgM than the IgG, just in principle. And that's a whole nother issue of discussion, but I'll leave it at that. So we were still looking to see whether this patient that we had found would be a suitable candidate, you know. So we did something else. We did cytotoxicity study with that particular patient. We did looking for, you know, percent cytotoxicity. That means you throw complement into the game. So you incubate the cells and his serum with complement. And that means if you've coated the cells, like in that previous slide with IgG or IgM, it may not do anything. It may not actually be deleterious. And the way to find out then is to throw complement into the culture series, and then if those cells die that have been coated by IgG or IgM, you know that was probably a bad antibody, right? So you can get these false positives in all this testing. So testing was for CDC. You can see that the one in the middle is red. That's a human that had high antibodies, and with CDC, a lot of cytotoxicity. Our patient's way on the left. Our patient didn't cytotox at all to this donor. You know, you can look on the right-hand side, the red dots are just dying cells. That's dye to look at cells that are injured, right? So that's the middle group, that's human high serum. So all those things cytotoxed out. Our patient's on the top panel there, you can see very few of those cells that died. And then complement only in cells where they didn't add the antibody is shown in the bottom right. That's kind of just control. But anyhow, so we said, okay, let's go for it. Right or wrong? You know, maybe we'd wait a whole nother year to find somebody with low IgM, but we probably wouldn't get any better cytotoxicity studies. And again, this is art science, and let's make our best shot, you know, whatever. Okay, so we did it. We did Dave. And we ended up with a pretty good looking heart. That should come back to us. That was the wean. We kept him on ECMO. Remember, he'd been on for 50 days. We just kept him overnight on ECMO because I was scared to death the heart was going to have a fibrillation or something. You know, pigs' hearts are a little twitchy. I was even twitchier. And the cannulae into the groin were really in a situation where they were, you know, they're so long that we weren't just going to be able to pull them out and use a percutaneous closure or anything like that. So we brought them back and used a stent closure from the inside, actually, to stay away from not so nice track. We didn't want that to complicate things. So anyhow, that was going to take a while. So anyhow, we weaned him. He never saw an inotrope post-op. Not any epi, nothing to get off bypass. It was quite remarkable, right? It was a good heart. Post-op day 4 looks pretty good, you know, and one of the nice things about this thing, and I like to mention how important the nursing was for us and the physician care. It was quite a remarkable effort in my mind that was universal across the ICU at Maryland, and I'm deeply indebted. This young lady in the back, who's his bedside nurse, also works in the lab taking care of the baboons. So it's kind of nice to have that, and not often finding that anymore. It kind of made me feel like the old days, you know. Immune suppression. So I told you what the ideal immune suppression was going to be. Well, guess what? We didn't quite reach that goal. And this is complicated, I understand that. But if you look at the KPL 404, it's given intermittently, and it doesn't seem any rhyme or reason up there, right? That's because we had to send the trough and the peak to the company in Boston. They were up all night trying to get us results, but when it was the weekend and stuff, you know, we would be delayed. So we had a stutter-stepping kind of approach to this. We thought we knew how much to give, we didn't. And then we found out we were shy, we had to give more. And so that went on through the whole deal, but you can see it's stutter-stepping. You can also see that one of our key therapies, that's MMF in red, right? That's like our maintenance go-to, right, in this, because we're given the KPL. KPL, I want you to think of, you allotransplanters, think of that as your tack, okay? KPL is critical. If we stop it, we're sure that we're going to be in trouble. MMF kind of just keeps you cool, you know, so you want to stay on that, just like in the allo world, right? But we had never had a monkey where we stopped it and had any success. This patient's immune suppression had to be stopped, in essence, because his white count just bombed. No big surprise. We started with a white count of 3, you know, and a platelet count of 90. So we were swimming upstream from the very beginning. Was that a good idea to do a patient like this? I don't know, a couple knocks, right? So IgG was a little higher than I liked it, not cytotoxic. The white count was a little lower than any transplanter would have liked it. When's the next patient going to come along that might be desperate and need this kind of procedure? So anyhow, we had to bridge and really kind of fly by the seat of our pants with respect to that. So in spite of our ignorance, nature took over, and this is his heart at 43 days. Cardiologist here, I'm going to take that course so I'll understand this, right? You know, it's cardiology for the non-cardiologist. My cardiologists tell me that this is a strain echo, and a strain echo is different than a standard echo. It shows longitudinal strain, which is how well the segments are contracting, basically. So it just gives you another look at it, and you can quantify it. So this was a very normally contracting heart at day 43, and I would say any transplanter who had a heart like this at 43 today would say, nice job, you know, on to the next case. So we were kind of high-fiving ourselves. He had had a lot of complications. We were kind of riding that roller coaster through a couple of laps in his belly for different things, and oh man, whatever. I don't want to tell you all about it. There he is. I mean, I know he doesn't look great, but he's gone through a lot. He looked like this pre-op, remember, you know, so it's like, my goodness. He has so much sarcopenia. We were actually talking about where are we going to send him now? We really never thought he might live long enough to need to go to rehab. So now we're going to rehab somebody with a pig heart. And I must tell you, it was quite an emotional experience to sit on this man's side of his bed and talk to him. You know, we went through the Super Bowl with him. He watched the Super Bowl. He helped us sing God Bless America. I mean, he reunited with a strange family that he hadn't been with for a long time, and, you know, would bring tears to your eyes, frankly. He had a pig's heart. I mean, I'm sorry, I still can't believe it, you know, and that's the thing about this case. You know, it still just inspires me to do another one. All right, one little problem. Okay, I told you about some of the problems yet. Here's another problem. we were doing something called cell-free DNA. Transplanters understand that because there's some of that for rejection data, looking for different things. But the package that Carius gave us also had some bugs in it. In other words, real bugs, microbes, right? So we could look for different microbes. They have it for E. coli and this and that. So this is a metabolic test, basically, where you can use in the future, I think, to determine what's going on with your patient. So they picked up this animal virus. It's called PCMV. It's actually a herpes virus. But strangely, we picked it up on day 20. It started to come out in the results. And our ID guy comes up, he says, this can't be, right? We have 4 preoperative tests that excluded this, right? But this is a latent virus, just like your cold sore. It doesn't express itself systemically unless it gets reactivated. So the little piglet gets it from mom or some other pig. It flies around for a while, and then it goes to sleep. And for whatever reason, in the past, they thought they had the right PCR to find it. Just like you were looking for virus, we looked for virus 4 times in this pig's nose, the donor. That data went off to Minnesota, where all of these studies had been done for years, and they thought they had a good test. Well, it wasn't reliable because here it is in our patient, and we transplanted a virus with the heart. Oh, geez. Now what are we going to do, right? We called everybody we knew in the field, and they said, well, just give this high-dose antiviral. You should be okay. But we've never done that because nobody's ever gotten this virus as a human. Nice. So we start to hammer up on his antivirals, but the antivirals, as you know, are also rough on the platelet count, on the white count. So we found ourselves in the same situation we did with MMF, where we had to come back on the antivirals. And as we did so, look at that climb of the cell-free DNA. That's the virus is in the blue there, okay? And the other thing that they're tracking in the red is basically shed pig DNA in the blood. And you know, every organ will shed cells as it senesces, right? And so you pick up pig DNA. We expected to find that, right? It's just the heart is, you know, going through its flush sequence, basically, of dead cells, old cells. And so we expected that. But what we didn't expect to see was the blue line increase beyond those cells. And that suggested to the virologist that perhaps this had reactivated, right? It's a big difference between just finding it as part of a shed cell and it's not activated, right? Well, and you can see it makes sense because we had to back off on the immune suppression. We did give him immune suppression, so that was the stimulus for reactivation, right? Even though it's no longer in the pig, there's no immunity to keep it from reactivating, and we had to back down on the drugs that would kill it. So there it goes. Well, what does it do? I'll show you what it'll do in a minute. About the same time that line was going nuts, we also had a patient that looked to be septic. All right. Now, please understand, I have this data now. We didn't have it then, right? It took us about 10 days to get the cell-free DNA back, right? So all this is happening in real time, and we're just kind of in a dark room as a blind man, literally, right? So we're trying to repiece it. When you see that troponin in green rising on this slide, it's days on the bottom, and it's relative MFI and its levels on the right side. But you can see the green line going up. That's heart leaking troponin. All right, so we're losing heart muscle here. Why? At the same time, we see that the virus is exploding or potentially growing. And during this septic-like episode, first time the guy was sick at like 43 days, we measured his existing IgG, and his own immunity was so lousy that his IgG was at 170, I think. It's supposed to be 1,000. So we gave IgG to him and didn't think much about it. I'm going to move on through here because I think it's less important to the talk. So now we have the same kind of slide, although now we're looking at that troponin leak on the top, okay? And then we're doing these echoes. And the echoes we were so proud of and I sent home to Mom, all of a sudden began to change a little bit. And if you look at the green and the Christmas slide in the middle, the green is left ventricular posterior wall dimension, okay, or thickness if you wish. So you can see as we wander out across the slide that the heart is getting thicker, and that beautiful strain feature is getting less. So there's less squeeze. Thicker heart, less squeeze, right? And the bottom slide is again the evidence of the viral DNA in the blood. It kind of goes together. Let's see if I can make this work. Come on, girly girl. Okay, so that beautiful squeeze ain't so beautiful anymore, right? And that goes along with the strain change, right? Just to give you a picture of that, right? And let's look at the echo. Same thing. I mean, this is terribly discouraging, right? And we're thinking all along here, I'm sorry, not working so good, kids. There it goes. We're thinking, my God, what happened to his heart? It blew up overnight. It stopped squeezing, it's thick. And this patient basically, within 24 hours, went into acute diastolic heart failure. What does that? Overnight, heart got thick, couldn't fill. It still had systolic function, but it got so thick, it just couldn't open, right? Couldn't relax. I don't know anything in clinical medicine that does that in 24 hours, right? We're talking about like an amyloid heart, but that's over a lifetime, you know. So anyhow, we were thinking, oh boy, I bet we've got virus in that heart. It reactivated. Guess where the virus lives? It lives in the capillary endothelium. So if the virus blew up, perhaps the heart blew up, began to leak, you know, whatever. This was the first biopsy we did. And I'll ask you to kind of just sit back a second and look at the top two. This was at day 34, before we had the septic episode, right? This was what I call the satisfaction biopsy, where based on that middle, that's a trichrome, but that's what it looked like. H&E really looked like that. We've refocused it. I ran around the hospital and showed the guard at the front door what this looked like. I was just so happy, you know? It's one of those happy days. And it took me all afternoon to show it to all my bosses, yeah? And I think we both talked last night about the key to success in academic medicine is to have a lot of bosses, because then no one of them really knows what you're doing. But when you get to the point where you got to show it off, it takes all day. But I was telling everybody probably the wrong thing. Like, this is the best biopsy ever, right? We began to think, now I want you to kind of hang in here with me for a minute, because there's another alternative. Maybe it wasn't the virus. Maybe that was an epiphenomena. And I'll show you why that might be. So this was his first biopsy, and the smart guys in the histopathology lab began to look very closely at this. Not the day that we all looked at it together. They went back and looked at these things, and they began to look with staining. We saw no complement. You know, complement is a feature of antibody-mediated rejection. There was none of that, but we did have a couple stainings with CD4, it was pretty light, frankly. And then they started to kind of tell me with those arrowheads, oh gosh, maybe there's some apoptosis. I said, well, I've got apoptosis in my heart, and probably more than you, because I'm older than you are. But I just didn't take it too seriously. I thought we were all set. Maybe in retrospect, we were beginning to see some AMR. And then 55, this is after he had expressed illness, right? Now this heart's thick. The biopsy H&E on the left shows some swelling, some interstitial edema. The trichrome shows early collagen and early fibrosis. I can't see all the way over there. There are some microvascular thrombi, you know, just a few, not a lot, and that's a hallmark of antibody-mediated rejection, thrombosis, capillary thrombosis. The special stain was a little helpful, There was some, some IgG staining, very little complement, but some, okay? Nothing that would make you feel comfortable in an allo case. We got to go to pheresis. Oh my God, right? You would probably say, well, we'll give some ATG, make sure we're maxed on stuff, and we'll biopsy next week. Let's follow them closely. Well, he died. We couldn't get him better. We put him back on ECMO for a week. We did pherese him with the concept of, well, maybe we, we are in a rejection. We also gave a very toxic antiviral, thinking that we'd cover that one as well. But this is what his heart looked like. Imagine, the beautiful heart on the right, shown that we put into him, just got so thick. And it's marbled. It looks like there's death in there, and there was myocytes that died, but it was edematous, there was infarction, and it had doubled in weight, right? Literally over, this would be now 2 weeks, but it got there very, very quickly. The postmortem showed more of same. We saw more edema, we saw red cells within the interstitium. You only get red cells in the interstitium if you've killed some capillaries. That's how it gets there. Red cells get out of the capillary and go into the interstitium. So we knew we had capillary injury. We saw incipient areas of collagen on that trichrome in the middle. We saw rare clusters of monocytes. There was very bland. There wasn't much interstitial inflammation, right? So that was the screwball thing. This looks like a heart that just, the capillaries blew up, but there was no inflammation in it, right? So you would expect in an AMR to see a lot of monocytes and a lot of things. Didn't happen. Okay, so we're really smart at Maryland, so we looked really hard with a great big microscope and learned nothing. Upper left was that first biopsy, and that's a beautiful endothelial cell. That big old thing in that round thing, that's an endothelial cell nucleus, okay, and it's absolutely normal. So remember when I was saying to you, maybe we misread that? This was the picture I was wanting to run around and show my bosses, where it was perfectly normal. So I think mostly the first biopsy was pretty normal. I think they were overreading that stuff now, knowing things that we now know. The second biopsy, after he got sick, began to show some endothelial swelling, and then the latest biopsy, which was like 4 or 5 days after the middle biopsy, showed lysis of capillaries. But we couldn't find virus. There was no virus in the EM. If this was a virus that had exploded in the heart, wouldn't you expect to find it? And maybe we didn't find it because it was now almost 10 days and we jacked up our antivirals, and maybe we killed all the virus. But the virus left its disease. You still have a hickey on your lip for a while, and you killed all that virus. So maybe that's what we were seeing here. Oh, and the other thing is that all that stuff in the background, those are the blood vessels in a heart. If you digested a heart, that's what you'd see. So the heart's got lots of blood vessels, right? So if you blow up the heart's capillaries, it shouldn't surprise you. It's no different than when you turn your ankle on the corner and you look down and now your ankle is all of a sudden 3 times bigger than it was before you stepped off the curb. Well, I don't know. Steve Hewitt, who works at the NIH, was reviewing all this, and he thought he found a virus in a capillary cell in the heart. And that's what this stain is supposed to show. He also did co-localization using ISH, in situ hybridization, where he was able to see a couple of viruses, and when he did the ISH, he was able to locate them in the capillaries. But there weren't hundreds of these, thousands of these. There were just occasional, and we didn't see them on the EM. So we're still a little iffy. I don't know, why weren't they on the EM? And we looked through the EM like crazy. We should have seen it. We chopped this thing up and we sent it off to the smart guys who can measure stuff like RNA transcription factors. And guess what? There were RNA transcription factors in the right ventricle, right, which went along with viral replication. So that locked it in. Definitely this virus reactivated, and that went along with what we found in the serum. The patient was never infected with the virus, though, from a traditional perspective, in that none of the other organs in the patient had active virus replicating. Okay, found it in the blood. We actually found it in some of the organs, but it was just like dead virus. I'm going to let that go. These are the, this is our hopelessness in trying to keep this KPL drug at a level that we were comfortable. Our level that we're comfortable is the blue dotted line. Roughly 50% of the time we were below threshold from what we wanted to achieve vis-a-vis our laboratory work. And we kept jacking it up. The company was really nervous that we were going to exceed their toxology thresholds that they had studied, and if the patient's head blew off or something, then the FDA would never let them get their drug approved because they'd claimed their drug. So we were fighting a battle, with the company that was so kind to let us use it in the first place. Is it a great idea to use a drug that's never been used in man? I don't think so. Did we have another one to use? No. What would you have done, right? So we did our best. And again, these didn't come we didn't order them in the lab. It's not like you could look in your EMR and see, oh, well, the drug this afternoon was a little low, let's give some more tonight. This took 3 days to get back. So we're all over the place and panicking all along. So EMR is not, AMR, it shouldn't be so far off the screen here, right? Even though the histology wasn't perfect, there were a lot of suspicions about it because we didn't give the immune suppression we wanted. He had a little IgG on board pre-op. All that stuff was a little scary. The other piece of this is the IVIG. That was my great idea. Oh my God, he's looking septic. No wonder he's septic. He doesn't have any he doesn't have any IgG on board. So we gave him 2 doses of IVIG. Well, we thought it was all right. There was some literature to suggest it might be. Well, it probably wasn't all right. And it wasn't all right because guess what the IVIG had in it? A ton of human anti-pig antibody. Okay? So here's sick patient. Let me give you some more of that anti-heart stuff that's maybe killing our heart. So unknowingly, I might have done it. You can see the first 3 bars on that left-sided slide. That is the binding of IgG in 3 different lots of IVIG. We didn't save the lot. We didn't save a little bit to send off to the lab. And it was only retrospectively that we took the same manufacturer's near lots and measured it. And we found that there was significant binding to the clonal endothelial cells. That's what that A328 PAEC, that's arterial endothelial cells from the clone. So we have those growing in the lab. That's how we did our antibody stuff. So anyhow, the only thing we had going for us in that regard was, again, we didn't see cytotoxicity with this antibody. So we hoped that it was just something that would coat the heart but wouldn't initiate a cytotoxic event in and of itself. But did it add to the problem? It didn't help it. Didn't help it. Okay, so this is part of the new. Does anybody know what single cell RNA means? Analysis. So the idea here is to basically look at a ton, like 2.5 billion samples, are being done looking at RNA samples from the immune cells in this patient. And you're trying to find out whether any of those samples have a trend in terms of one way or another. Is there some RNA that's up and down? You're trying to find out, is there a blueprint for what's gone on in the patient by looking at the RNA of the cells that are in the immune area. And that's what this is. And what you can see is that day 38, which is the second day over, upper left one, that is looking at 200 genes, okay, known to be associated with allo rejection. And so you can see that little whisker plot is high at 38, right? Were we turning on the immunity in a rejection phenomena at day 38? Was that going on? Is that what that signal tells us? Certainly the other plots show there's an up and down inflammatory response going on. But this is as close as this big time science can get us in terms of a mirror of what happened. But we're working on it. Oh boy, sorry, surgeons. Just close your eyes. It's not that important. This again shows B cell activation cascades. Again, using the same RNA sync studies, just a different format. The different genes are shown on the bottom across and up is what classification they are. And if you look where the red is, you'll see there's a consistent pattern of B cell activation genes that are being picked up. Okay, so we got B cell activation, we've got maybe a rejection phenomena based on an allo 200 genes, and then we have all that histology, and so there is concern, right, that we might have had a rejection in this patient. This is another way to look at the same thing, clusters of B cell activation. The genes on the left, on the right is the nodes that basically tell you have different areas of activation with those genes driving it. So Dave's heart blew up, and we're not really sure why, right? Just blew up. What are we going to do? Should we quit? What's your recommendation? Do we give up? Was this just a stunt? Have we proven that we can't beat the xeno reaction? I don't think so. I think I've been really honest today about where we screwed up. I could have spent the day telling you how we did things really well too, right? But I do think that the patient was so sick pre-op that he was probably too sick for anything. If he had qualified for allo because of his he was terribly non-compliant. Doctors told us that he was the worst patient ever. We decided we had a team that would badger him if he survived and take care of him, so we looked past that. That's an auto stop in most transplant centers. 4 other centers had turned him down. But his pre-op neutropenia and thrombocytopenia, while we managed the septic episodes that were bacterial in him, I think they so changed what we wanted to do with our immune suppression that it put him behind the 8 ball. It definitely limited our T and B cell targeted inductions, and we got lots of infections. We laid off MMF right in the middle of the course and couldn't give him the antivirals we wanted. We gave him IVIG, that's my brilliant idea. And the latency of the PCMV that we missed probably became active. Did he have a bland AMR, meaning a non-inflammatory AMR, one that just, for some reason, very little complement, but somehow antibodies, and our kidney guys will tell you that'll happen. They see AMR without inflammation, just with antibody-mediated AMR. Maybe that's what we had. And again, what's the effect of these genetically altered animals where, we basically try to control complement, on the surface. So we have complement inhibitors and other things that reduce inflammation. So maybe we just won't see quite what we expected in the allo. Our monkeys show much more when they reject. Let me just tell you that. And that's the transgene effect that I just mentioned. So I think we're gonna let that go. I think the consensus might be that we should keep at it. It's been more than a year. January 7th was a year. We believe that we finally put everything together that we can. There's a publication, hopefully it'll be in Lancet soon, that kind of summarizes some of this deep science stuff about this. Tom Starzl, great transplanter, when I lost our very first heart-lung transplant patient from poor preservation because we flew for the organs, as opposed to bringing the donor in, that patient's lungs flooded. He said to me, Bart, he said, well, you better hurry up and do another one or get out of the field. Because, when you have a small series and you lose your first patient, what do you do? I hope we haven't lost your faith. I hope that a place like Methodist, who's done so much for transplantation across the board, will get interested. We have a working group called X-Wing that you're welcome to join. We meet every Tuesday, so it'll be first Tuesday of every month, and we have a science piece, and we have just an update where we are, because we are starting to look for another patient. If you think you have a patient, we'll find a way to get him to Maryland to get a heart. It will be a few years before you will have an opportunity to participate in what might be multi-center trials, because the FDA has to get there. The data we learned on this case will support a far better protocol, right? We have a better test now. We can pick up the virus. We've learned a lot, right, about what we can do, what we can't do. So our next patient hopefully will benefit. And once we get to protocol for the broader IND, right, multi-center, hopefully those centers won't have to relearn, the very basics So thank you. That's what I had to say, and maybe we can have a chat.
Thank you very much. A fascinating talk. Open for questions.
Dr. Griffith, thank you very much, and very inspiring, and it's an honor to be here in your audience and listen to you present and with such humility. And I think, you know, from our
You're
field,
inspired. I'm perspiring.
no, you're a hero for taking this forward. And again, I think we're definitely, I think the field should keep going and growing. Couple of questions from the science part that you mentioned, and I don't know if this is the next phase that we have the ability to. Two specific questions are, do you think there's a need to do a biopsy of the donor heart to look for DNA expression of viral presence? And I don't know if you can pick up dormant one. And then my second question in the context of IgG is there a role for a synthetic IgG so you get away from the human aspect of having the antibodies against the pig?
Yes, we can do better IVIG. That's the easy answer. And in fact, you can screen lots that have low levels. I didn't know that. I honestly didn't know it, right? How much IVIG have I used in transplant patients? Maybe we should be cross-matching that against the donors, you know, particularly the sensitized donors, you know, so be careful. I just didn't know. That virus is everywhere in the pig. It's not just in the heart. So you can do a tail biopsy. Usually ear biopsy is what is safest. These pigs are precious, right? Because they're cloned. Once they got full expression, you know, they're great. The problem that Revivicor has with the pig deal is to become commercial, those pigs can't be cloned that you buy. My pig was a cloned pig, and it takes a long time to make it happen. 2 cloned pigs have to have babies in order to have a commercial deal. And they're a little less interested in each other than one would think. And it started to happen when they gave the growth hormone knockout. So it might be, you know, you change something. It's, you know, Joe Tector, fabulous liver transplanter in Miami now, he's trying to wipe out pig SLA. SLA is like the human HLA, about 80% similar. Right? If he can do that, then all the kidney patients waiting for transplants who are sensitized, right, can have a pig kidney probably. But again, those pigs without SLA aren't always well. So genetic engineering is still a mystery, right? And it's taken them 10 years to get these 10 genes in. Now, boss.
Oh,
Hi.
Thank you. Sorry, I'm just. Thank you so much for this talk. I've listened to this talk several times, and I've one question that I keep thinking about. Do you think treating the virus was a problem? Because I know that, you know, with microbiome, they can interact with your cells in a way that if the cell starts seeing that there is virus that's dying, it can set off apoptosis pathways. And do you think the treatment had something to do with how this, you know, the cell death occurred and the process of apoptosis propagated?
I'm not a virologist, and you must know more about this than I do. I know that most of us would say kill the virus if you can. Consequences be damned, because the virus is killing your heart. And I think that played a role in this case, right? I think the virus was real, and I think that was real virus in the endothelium, and I think the way it happened so fast, and it just blew up, and then I think when we treated, we knocked the virus down, right? Because I don't know whether you noticed, but in the cell-free DNA of the virus, it went up and then it came down. Unfortunately, we were phoresing at the same time, so did that, pherese that stuff out too as our measurement, so I'm not really sure. It's a great question. We do think that the combination of maybe an early AMR and inflammation from the virus, that combination's not good, right? So, and then throw in a little IVIG, and maybe we have a witch's brew, of 3 things that maybe we could have controlled one of, but not all 3 together.
So if I may just suggest one thing, and I'll stop there, but for your future pigs where you do would you consider giving antiviral therapy and then seeing what would happen to the heart without the actual transplant? Because does it set off a pathway of sort of failure for the heart? Because these viruses coexist with your heart in animals without causing any problems. But if we treat them, what happens to that latent virus? Does it run amok?
Yeah, the non-human primates do receive antivirals of this class. Cedidifer was something we had no experience with. That's a big-time antiviral, and that's what we gave in the end. So that was all new. And maybe that did do something. But we can talk offline about this, and we have a wonderful infectious disease guy, Kapil Sahara, who is just terrific, and I'll give you his contact, and I take my orders from him.
Well, Bart, listen, thanks for visiting us in Houston. It's such a pleasure to have you here and a great talk. I'm not going to comment on the science because I just would embarrass myself. But I will answer your kind of question of what do you do? You got to press on. I remember when I heard that you did this, I was so excited by this. And medicine is replete with things that fail initially, then become everyday common practices. And one of the problems is we do these difficult things in the sickest of sick people. And we all know that if you really want good results, you start with the healthiest person you can. So, God, please press on. This, I would like to live another 40 years so I can see where this ends up.
Thanks.
Because it's been 50 years since the first transplant. And I do think that it's eventually going to be brought to fruition. I'm so excited about your talk. I was really excited to have it. So no question, just kind of press on with the team. Really great work.
I treasure your text that I received early hours after doing this procedure. Thank you very much for your support. And the key is, finding the right patient. And that's a whole symposia. And this X-wing, this Xeno working group, whatever, is challenged with that. And if you email me, I'll get you on that email, on that Zoom call. Please come and contribute.
So, Dr. Griffith, a brief comment. Excellent talk. As a transplant nephrologist trained in Minnesota, you remind me of one of my mentors there, David Sutherland.
Oh, yeah.
Who was a pioneer in pancreas transplant and pancreatic islet transplant. And I completely agree that this is groundbreaking, this is fantastic, and I would not give up. I would just keep using everybody's input and press forward. Thank you very much.
Thank you so much for that kind comment.
So I would just also like to, thank you again, and as Dr. Bimaraj said, for the, humility of presenting your failures, and helping us see those. And I wouldn't consider them failures. I would just consider them the next challenges. But I do agree with you. I think the immunology of this is incredibly complicated in our ability to understand what rejection even looks like in these patients, as you pointed out. And so I also praise you for embracing the technology we have with the molecular aspects and really that, because I agree with you. I think that's probably the bigger crux of what happened, but embracing that and looking forward to how not only managing the immunosuppression, but also even trying to how to monitor. And I think you opened our eyes to, just when we think we understand something, we realize how little we know in those areas.
Well, Dr. Martin, you're crack on here, and you would think that the science should be in the lab, right? We should be able to translate what we've learned from all of these baboon studies, right? And we've done a ton of them. Each baboon study is about $500,000 to $750,000 in cost. Okay, so when you start talking about, well, let's biopsy every week and we'll really see what's going on in that monkey, it's like, nah. We lost a monkey this week. 2 weeks after a perfect heart. Heart was working perfectly. Something happened when they put the animal down. They were doing echoes and they were doing all the stuff that we really didn't need, frankly. And I got this urgent call. He fibrillated. They put the paddles on. They couldn't get the paddles to discharge. The animal fibrillated, right? So they ran up to the next lab to find paddles. This stuff happens, and it happens, on the floor too, right? But when you're in a medical school lab and you're taking care of basically a heart transplant patient, good luck, So it's hard. So the more you do to these animals that are so precious, the more you're going to run into trouble. So at the cost of science, So molecular probes are really neat, right? They do just let you take a piece of stuff. And this molecular stuff, it'll be I'm sure if you get into it, you look at cell-free DNA and you look at some of this RNA sync stuff. RNA sync is really expensive, but that'll all come down if you know what to look for. So it's a little bit like, the molecular probes we now need, we use for allo just to rule out rejection after the first month, right? Pretty good stuff.
Yeah, and I think, like you said, we all know that no experimental animal is going to replicate humans. And so at some point, we just have to take the best information that we have And sometimes I wonder if learning more in some of these animals doesn't hinder us, because we think
I
we
wish
know
you were on the
more.
FDA.
And I will go to Dr.
We'll make sure you're the consultant, all right?
One last question by Dr. Page.
Yeah, but
Do you, well, several.
Oh, boy.
What about baboons? Did you ever transplant baboons? You know, Reemsma had kidneys, lasted 9 months with just a baboon. And the baboons are not very human friendly. They,
there are non-human primates, so I've got a lot of ex-friends that have been baboons.
yeah,
Well, I have some friends that are baboons, I think.
well, the baboons, when we had them, they were just mean as hell.
Yeah, but let
And
me
they're
put
very
that
strong.
let me put that to rest. I think you're correct. It's an easier model, right? And there has been good success. By the way, kidneys are coming. I think we shocked the Xeno world, who expected a nice little plan for the first one being kidneys, right? Because the kidneys are a little easier, you know, and I think we're going to get kidneys maybe even before that, 2024. But nobody working on the kidneys has the non-human primate work that we had to justify going forward. The FDA has turned down all requests for human trial, even onesies like we did, right, as a compassionate, because none of the applicants had the long period of justification in the non-human primates. But when you choose an animal organ, the pig was chosen. It's commercially viable because you presumably can get a whole lot of them. You know, once the clones start to have babies, then you can have lots of them. They only take a year to get to size. It takes a baboon to get to 60 pounds 7 or 8 years, one baboon. So that's part of the problem. The cost of raising a baboon for 7 years, try that. And there is a social barrier, right? A baboon is too close to you and me relative to the pig you eat. I've got emails that I could show you that were pretty damning, you know. May you rot in hell for this detestable whatever. Oh, so your pig heart died. How's the pig? You know, people have strong feelings, right? So if we were doing a non-human primate as a donor in this era, even if we could raise them, you know, if we could afford it, if they got big enough. Baboons don't get quite big enough. You get a big enough kidney, but now we're talking about a full heart, right? So it's a little bit of an issue. And you know, the Hardy put a heart in that was too small to carry a patient. Patient basically died from low cardiac output before rejection happened. So I do think that, and I get this question a lot, Bud, it would be nice if you had a closer match. I think the secret sauce is in the engineering. I do think we're going to get there. I'm not, but, you know, smart people are going to figure it out.
That was an odd-looking heart.
I beg your pardon?
No, the heart, the postmortem, without any sort of cavity. But no,
Oh, yeah, well, it was,
right there.
yeah,
It's
but
a little
when
odd looking, don't
when
you
it
think?
started, it looked like the upper right. It's after I messed it up that it went to that.
Well, we saw a lot of that in the earlier heart transplants, a thickening of the
Yeah.
myocardium, but not
Yeah.
not to that degree. Do you think you could do 10 of them without the media getting involved?
Why would I want to do that? It was
It'd make it
fun.
a little more. It would be a little easier from a scientific standpoint.
They slammed the door on this for, we did the procedure and that didn't say anything for like 3 or 4 days, and then it started to leak out. I think it would be very hard. And I think we need people to be with us, you know. And frankly, we've taken a year and a half to study what we did right and wrong, so, you know, and we had an anniversary party for Dave's family. They were wildly enthusiastic and still thankful. They didn't feel like, you know, they didn't feel like we took advantage. There is an ethical issue when you talk about therapeutic intent, and you've got to be sure that your patient, David, knew this was an experiment, And he was more likely to die, and I was more likely to learn something than he was to benefit from it. And he understood that. He was seen by 4 psychiatrists, 1 extramural, and he was seen from day one by our ethicists, who assured us that in spite of his frailty and his illness, that he could make decisions he understood. So all that stuff goes into it. This is tough business, yeah. First 22 LVADs died.
Yeah.
Yeah.
Nobody cared, because nobody knew what an LVAD was. If they'd been total artificial hearts, we would.
Tom Starzl, we all know Tom Starzl. He was quoted that, you know, he followed the blitzkrieg phenomena. He said he just worked really hard at something, did a whole lot before anybody understood what was going on. You know, and that was the way he avoided all this. You can't get away with that now. I mean, you know, imagine what our medical school was like and our hospital when I told them we got permission. They couldn't believe it. They made me show them the FDA response, you know, that the lawyers were all running around like cuckoo birds, whatever.